Hello and welcome to the online lecture on substance use disorders. The objectives for this lecture include the following. Describe the diagnostic criteria of substance use disorders. Apply the theoretical perspective of substance use disorders and addiction to the clinical setting. Discuss the presentation of specific substances during intoxication, overdose, and withdrawal. And finally, employ appropriate management principles in the care of patients with substance use disorders. Substance use and its associated complications is a significant problem in the United States. According to one article, in 2015, the age-adjusted rate of drug overdose deaths in the United States was greater than 2.5 times the rate in 1999. The age-adjusted rate of drug overdose deaths increased from 6.1 per 100,000 standard population in 1999 to 16.3 in 2015. This is an overall average increase of 5.5% per year. Adults between the ages of 45 and 54 had the highest rate of drug overdose deaths in 2015. According to the National Institute of Drug Abuse, the use of tobacco, alcohol, and illicit drugs is costly to our nation, exacting no more than $740 billion annually in costs related to crime, loss of work productivity, and health care. Drug overdose occurs more commonly in males compared with females, and it's more frequent among non-Hispanic white individuals. Here I've provided a definition of addiction. Addiction is repeated involvement with a substance or activity despite the substantial harm it now causes, because that involvement was and may continue to be pleasurable and/or valuable. Regardless of the substance, two or more of the following diagnostic criteria must be present: impaired control, social impairment, risky use, or pharmacologic indicators. Impaired control includes some of the following behaviors: using a drug for longer periods of time or larger quantities than intended. The individual may want to reduce the use of the substance, however their attempts are unsuccessful. Spending excessive time getting, using, or recovering from the drug use. And experiencing cravings that are so intense that it's difficult to think about anything else. Social impairment is a type of substantial harm or consequence caused by the repeated use of a substance or an activity. Often there's use despite problems such as repeated work absences, poor school performance, neglect, or failure to meet responsibilities. Important or meaningful social activities may be given up or reduced because of the substance use. Risky use involves the failure to refrain from using the substance despite the harm it causes. It also involves the use of the substance in physically dangerous situations, such as drinking and driving. And finally, it can also involve continued use despite knowledge of existing problems as a result of the substance use, for instance, the presence of COPD and smoking. The final diagnostic criterion is pharmacologic indicators. This includes tolerance, dependence, and withdrawal. Tolerance involves the need to increase the amount of a substance to achieve the same desired effect. It's important to note here that the desired effect may be the avoidance of withdrawal. In dependence, the organism functions normally only in the presence of the substance. Physical disturbance often occurs if the substance is removed, as occurs in withdrawal. Finally, withdrawal is the response to abrupt cessation of the substance once tolerance has developed. This results in unpleasant and sometimes, or rarely, fatal symptoms. Let's take a look at some of the theoretical underpinnings of substance use in relation to predisposition and precipitation. This image shows three dopamine pathways. Of importance to substance use is the mesolimbic and mesocortical pathways. In the mesolimbic pathway, stimulation of the amygdala and hippocampus occurs. This is the area where emotion is associated with memory. In the mesocortical pathway, the prefrontal cortex is stimulated. This is the major area of executive functions such as goal-directed behavior, attention, information processing, planning, and problem solving. According to the Psychomotor Stimulant Theory, addictive drugs cause psychomotor activation, are reinforcing, and elicit approach behaviors. The mesocorticolimbic dopamine system is associated with the neural approach system. Therefore, people initiate and maintain drug-taking behavior because drug-induced dopamine release has reinforcing effects and activates motor systems that result in repetitive drug approaches. Incentive stabilization theory builds upon the psychomotor stimulant theory. Incentive salience is a type of motivation created in the brain because it has developed an association between a certain stimulus and a reward. This stimulus will be whatever drug the individual is using. Repeated exposure changes the way the brain operates. These individuals then become hypersensitive to the drug, and this means that the substance can now stimulate non-behavioral systems significantly more than before. The outcome of this change is that people start to receive increasing amounts of pleasure when they use drugs. This leads to incentive salience and an increasing preconscious desire for the substance. As the individual takes more of the substance, it only leads to more sensitization. The preconscious desire then becomes a conscious obsession. Therefore, as a substance use disorder develops, a person's motivational focus narrows to drug seeking at the expense of natural reward seeking. This theory helps to explain relapse after recovery. Even though an individual no longer takes the substance and has made it through withdrawal, the sensitization to the drug will still be there. The effect of this is that the individual may still experience cravings for the substance or unconsciously continue to want it. The aberrant learning theory further explains the increase in incentive salience of drugs. According to this theory, there's a gradual shift from ventral to dorsal striatal mechanisms, resulting in drug seeking and taking that becomes habitual or automatic. Sensitized responsiveness to drugs and drug cues becomes immune to punishment, resulting in a core symptom of substance use disorders, which is continued use despite adverse consequences. According to the Frontostriatal-Dysfunction Theory, people with substance use disorders tend to have poor impulse control. Repeated drug use leads to alterations in cortical and limbic circuits such that an individual displays pathological responses to drugs and drug cues while simultaneously displaying impaired inhibitory or top-down executive control over drug-seeking behavior. This leads to a loss of impulse control, poor decision-making, heightened responsiveness to drug-associated cues, and compulsive drug use. According to the Hedonic-Allostasis Theory, initial drug abuse is motivated by positive reinforcement obtained by the drug's rewarding effects. Chronic drug abuse is motivated by the negative reinforcement resulting from the recruitment of stress-related systems and emergence of negative hedonic states. This chronic drug-induced negative emotional state, or hedonic allostatic state, reflects a persistent change in the animal's normal reward set point. According to the Psychoanalytic Perspective, addiction is a defense against helplessness or powerlessness. Drug use is an attempt to compensate for inner emptiness. The use of drugs supplies a feeling of acceptance and feeling of temporary self-confidence, and the addict substitutes an imaginary world where he or she is in complete control for the real world where he or she feels useless and out of control. Addiction is basically then a disorder of self-regulation. To give you an example of this process, let's say, for instance, an individual with a history of exposure to an adverse childhood environment, for instance, sexual or physical abuse, may tend to have a diminished capacity to regulate negative emotions and cope effectively with stress. These individuals may then self-medicate the resultant psychiatric disorder. Over time, the ability to delay gratification is impaired, with resultant problems in impulse control. Now let's look at some effects of specific substances. Alcohol causes an increase in gamma-aminobutyric acid, resulting in central nervous system depression. This often begins at the cortical level, then progresses down towards the brainstem. Here I've provided a table with the effects of alcohol based on blood alcohol concentration. At 20 to 50 milligrams per deciliter, the individual will experience diminished fine motor control, relaxation, and decreased inhibitions. At 50 to 100 milligrams per deciliter, the individual experiences impaired judgment and coordination and slurred speech. At 100 to 150 milligrams per deciliter, the individual will experience difficulty with gait and balance. At 150 to 250 milligrams per deciliter, the individual will experience lethargy and difficulty sitting upright without assistance. Coma occurs around 300 milligrams per deciliter. And finally, respiratory depression and cardiac depression occur around 400 milligrams per deciliter. In terms of alcohol intoxication or overdose management, airway and ventilation is priority. A good rule of thumb is Glasgow Coma Scale less than 8 intubate or GCS less than 8 intubate. For Wernicke-Korsakoff syndrome prophylaxis or treatment, thiamine with or without magnesium are given. Dextrose may be given for hypoglycemia. Some of the chronic effects of alcohol include esophagitis and toxic hepatitis, which leads to cirrhosis of the liver. This produces thrombocytopenia and ascites. Pancreatitis can occur due to spasm of the sphincter of Oddi, which especially occurs with binges. Cardiac disease, particularly hypertension, coronary artery disease, and cardiomyopathy can occur due to the lack of folate absorption. A lack of folate absorption leads to an increase in homocysteine. Patients are often supplemented with folate to prevent this. In alcohol withdrawal, there's a shift from the increase in gamma-aminobutyric acid, which is inhibitory, to an increase in glutamate with N-methyl D-aspartate activation, which is excitatory. The onset is often 4 to 12 hours, and it peaks within 2 days. The duration of alcohol withdrawal can be anywhere from 5 days to 2 weeks. Manifestations can include tremor, diaphoresis, anxiety, hypertension, nausea and vomiting, hallucinations, seizures, and delirium tremens. Alcohol withdrawal management involves monitoring CEWA, a benzodiazepine taper, and potentially a dual mood and seizure prophylactic drug. The CEWA scale allows for early recognition of withdrawal symptoms and monitoring. A score of 0 to 9 indicates absent or minimal symptoms. Usually prophylactic medications are given if the CEWA score is greater than 8. A score of 10 to 19 indicates mild or moderate symptoms, and a score greater than 20 indicates severe symptoms. Patients are initiated on a benzodiazepine taper primarily because benzodiazepines mimic the increase in gamma-aminobutyric acid. This prevents the shift to N-methyl D-aspartate activation. Drugs that are commonly used include lorazepam or Ativan, chlordiazepoxide or Librium, and diazepam or Valium. Dual mood and seizure prophylaxis may be initiated based on the patient case. This is often done with valproic acid or Depakote. On the following slides, I provided the sections of the CEWA scale. There are 2 agents for abstinence assistance and craving suppression. Disulfiram, or Antabuse, maintains abstinence from alcohol. Patients on this drug should be educated on the avoidance of alcohol, as well as the importance of reading labels. Acamprosate, or Camprol, suppresses alcohol cravings. These patients should be monitored for diarrhea, vomiting, and pruritus. This model illuminates the metabolism of alcohol in the system. Alcohol is converted to acetaldehyde by alcohol dehydrogenase. Acetaldehyde is converted to acetate by acetaldehyde dehydrogenase. Acetate binds with coenzyme A to form acetyl coenzyme A. Acetyl coenzyme A cannot enter the tricarboxylic acid cycle because of the excess in NADH from the preceding conversion steps. As a result of this, acetyl coenzyme A is converted into fatty acids, which builds up in the system in the form of triglycerides. With continued consumption, ketones build up in the system, resulting in alcoholic ketoacidosis, producing a wide anion gap metabolic acidosis. Other factors contributing to the metabolic acidosis in alcohol use includes the loss of bicarb, as well as the conversion of pyruvic acid to lactic acid in the presence of excess NADH. Anabuse functions by interfering with the conversion of acetaldehyde to acetate, resulting in a buildup of acetaldehyde. Acetaldehyde produces an unpleasant effect on the body. This is referred to as a disulfiram reaction and can also occur in other medications such as metronidazole or flagyl. It's interesting to note that approximately 40% of the Asian population lacks the enzymes alcohol dehydrogenase and/or acetaldehyde dehydrogenase. This results in a decrease in the likelihood of alcoholism in the Asian population, primarily because of the resultant disulfiram reaction. As we've discussed, alcohol produces a central nervous system depressant effect by the increase in gamma-aminobutyric acid. In withdrawal, there's a shift to increased N-methyl D-aspartate stimulation, resulting in grossly excitatory symptoms. Camprol functions here by decreasing N-methyl D-aspartate stimulation, resulting in a reduction in the sensation of craving. Also, as we've discussed, benzodiazepines increase gamma-aminobutyric acid and mimic the effect of alcohol. Benzodiazepines are tapered in order to move the patient through withdrawal. Sedatives, hypnotics, and anxiolytics include all central nervous system depressants, including barbiturates, non-barbiturate hypnotics, and anxiolytics, especially benzodiazepines. They have a similar effect compared with alcohol due to the increase in gamma-aminobutyric acid. Overdose is treated with gastric lavage or activated charcoal if within 4 hours, or dialysis if the symptoms are severe. Withdrawal is usually treated with a gradual taper, and the onset depends on the half-life of the drug. Cannabis binds cannabinoid receptors in the hippocampus, cerebellum, and basal ganglia. The onset is usually less than 1 minute, it peaks in 20 to 30 minutes, and the duration is 2 to 3 hours. Cannabis intoxication presents with the following symptoms: lowered inhibitions, relaxation, euphoria, affective inappropriateness, impaired judgment or memory, distorted perception of time, ataxia, increased appetite, conjunctival injection or bloodshot eyes, xerostomia, hypotension, and tachycardia. In some cases, cannabis intoxication can result in delirium and rarely psychosis. With cannabis withdrawal, you may see muscle aches, diaphoresis, anxiety, or tremors. Opioids function by targeting a variety of receptors, including mu1 and 2, delta and kappa receptors. The type of receptor dictates the typical symptoms that may be observed. Symptoms of opioid intoxication include euphoria, apathy, lethargy, listlessness, impaired judgment, psychomotor retardation or agitation, drowsiness, pupil constriction or miosis, slurred speech, and impaired attention and memory. Symptoms of overdose include decreased level of consciousness, usually on a spectrum between lethargy and coma, and cardiopulmonary depression. The treatment of choice for opioid overdose is naloxone or Narcan. Opioid withdrawal can present with anxiety, restlessness, muscle aches, cravings, nausea and vomiting, dysphoria, lacrimation, rhinorrhea, diaphoresis, diarrhea, and insomnia. The onset, duration, and peak really depend on the half-life of the drug. These symptoms cause distress, but there's no requirement for pharmacologic intervention. There are 4 agents that may be used for opioid abstinence. The first is methadone. This medication helps to maintain abstinence from heroin. The most commonly reported side effect is nausea and vomiting. The second medication is levomethadil. This medication helps to maintain abstinence from opioids. The dosing is spread out over 3 times per week and shouldn't be taken on consecutive days. With this medication, take-home doses are not permitted. The third medication is Suboxone. This medication helps to maintain abstinence from opioids and decrease cravings. Some of the commonly reported side effects are orthostatic hypotension and sedation. It's important to avoid central nervous system depressants when on Suboxone. Finally, naltrexone works by blocking the effect of opioids. When patients are on this medication, it's important to note that they may not respond to narcotics used to treat cough, diarrhea, or pain. The medication should be taken with food or milk. Opioid use and associated overdoses has significantly increased over the past decade. In 2015, the percent of drug overdoses involving heroin was triple the percentage in 2010, which was 25% and 8% respectively. For drug overdose deaths involving natural and semi-synthetic opioid analgesics, which includes drugs such as oxycodone and hydrocodone, the percentage decreased from 29% in 2010 to 24% in 2015. The percentage of drug overdose deaths involving methadone has also decreased, from 12% in 2010 to 6% in 2015. For drug overdose deaths involving synthetic opioids other than methadone, which includes drugs such as fentanyl and tramadol, the percentage has increased from 8% in 2010 to 18% in 2015. Stimulants includes prescription stimulant drugs such as Adderall, Ritalin, and Strattera, cocaine, methamphetamine, and khat. They primarily function by central nervous system excitation, primarily through the increase in norepinephrine. Here I've listed both the behavioral and physiological effects of intoxication. This can be treated with chlorpromazine or thorazine, which controls hallucinations, lowers the blood pressure, and relieves nausea. Stimulant overdose can result in seizures and coma. Death rarely occurs. In terms of management, the priority is cardiopulmonary support. The patient may be given antipsychotics and seizure prophylaxis medications. Withdrawal from stimulants can occur within a few hours to several days after cessation. Symptoms usually include dysphoria, fatigue, vivid dreams, insomnia or hypersomnia, increased appetite, and psychomotor agitation or retardation. Depressive symptoms may arise, including suicidal ideation. There's no particular agent for withdrawal. However, prescribed stimulants can be tapered over time to prevent symptoms. Hallucinogens distort perceptions and result in symptoms seen in psychosis. I've listed the behavioral and physiological effects of intoxication. Treatment is primarily supportive and includes isolation of external stimuli, sedation or restraints, seizure prophylaxis, respiratory support, and potentially hyperthermia blankets. In terms of withdrawal, there's usually no symptoms other than cravings. However, flashbacks with perceptual disturbances may occur up to 5 years from cessation. Let's talk about some of the specific hallucinogens, starting with PCP and related compounds. These function by NMDA receptor antagonism, and the compounds include PCP, ketamine, and dextromethorphan. Intoxication can produce a dissociative state, depersonalization, derealization, and cognitive impairment. Toxicity can produce hypertension, hyperthermia, seizure activity, and bladder dysfunction with ketamine. Classic hallucinogens function by 5-HT2A receptor agonism or partial agonism. These drugs include LSD, psilocybin, mesalamine or peyote, DMT, and ayahuasca. Intoxication can produce visual illusions, closed-eye visual images, mystical experiences, and anxiety. With toxicity, these patients usually experience transient psychological distress. In terms of management, antihypertensives are given for hypertension, and benzodiazepines are given for seizure prophylaxis and behavioral emergencies. Antipsychotics are carefully used because it may lower the seizure threshold, and it's important to aim for those with 5-HT2A receptor antagonism, such as with the atypical antipsychotics. And hyperthermia is treated with cooling blankets. NMDA and related compounds function by serotonin release as well as reuptake inhibition. These include MDMA and MBDB. Intoxication produces feelings of love, acceptance, and closeness to others. However, toxic effects include neurotoxicity, particularly with high doses, and hyperthermia. Kappa opioid agonists function by kappa opioid receptor agonism. The primary prototype here is salvia. This produces very brief, however potentially very intense, breaks with reality. In toxicity, salvia can produce QT prolongation. Anticholinergic deliriants function by muscarinic receptor antagonism. These include datura, scopolamine, and Benadryl. Intoxication can produce true hallucinations, and in toxicity, it can produce anticholinergic toxicity in crisis. The group of inhalants includes anesthetics, nitrates, and organic solvents. The most common used are allopathic and aromatic hydrocarbons, such as gasoline, glue, paint thinner, and spray paint. Less common are the halogenated hydrocarbons, such as cleaners, correction fluid, and spray can propellants, as well as other compounds containing ethers, ketones, and glycols. Inhalant intoxication can produce belligerence, aggression, apathy, impaired judgment, and inability to function, as well as dizziness, nystagmus, ataxia, slurred speech, tremor, weakness, blurred vision, and stupor or coma. Inhalant overdose, on the other hand, can produce anoxia, respiratory depression, vagal stimulation, and dysrhythmias. Death usually occurs from bronchospasm, cardiac arrest, suffocation, and aspiration of vomitus. Treatment includes cardiopulmonary support until the inhalant is cleared from the system. Finally, let's discuss some of the non-pharmacologic management principles for substance use disorders. First and foremost, it's important to provide information and educate the patient, as well as dispel any myths associated with substance use. Avoid the patient's attempts to externalize without relating their problems to substance use. Encourage identification of behaviors that have caused problems. Disallow rationalization of difficulties or blaming others or circumstances beyond the patient's control. Consistently redirect the patient's focus to his or her own problems and what he or she can do about them. Provide positive reinforcement for the identification and expression of feelings or indications of insight into behaviors and consequences. Encourage others to provide the patient with feedback. Encourage open expression of feelings. Validate the patient's frustration or anger by using the statement, "I know this must be very difficult." Make frequent contact with the patient to decrease feelings of abandonment. Give positive feedback for abstinence on a day-by-day basis. If relapse occurs, discuss the events that led to the incident in a non-judgmental manner. Discuss ways to avoid similar circumstances. Teach positive coping strategies such as physical exercise, expression of feelings verbally or via journaling, and meditation. Assess the amount of unstructured time with which the patient must cope. Assist the patient in daily or weekly planning, incorporating purposeful activities such as errands, appointments, taking walks, etc. Writing the schedule on a calendar may be beneficial. Encourage the patient to record activities, feelings, and thoughts. Teach social skills such as attentive listening, eye contact, and appropriate topics for conversation. Give positive support to the patient for appropriate use of social skills. And finally, refer for volunteering or vocational services if indicated. Alcoholics Anonymous is a self-help group designed by alcoholics in the 1930s. This group developed the 12-step program. It's based on the philosophy that total abstinence is essential and that alcoholics need the help and support of others to maintain sobriety. People early in recovery are encouraged to have a sponsor to help them progress through the 12 steps. Once sober, a member can be a sponsor for another person. This has been successful for many people, however, it's not effective for everyone. Some of the problems include the following. Some individuals object to the emphasis on God and spirituality. Others do not respond well to the confrontational approach used in treatment. Women and minorities have reported the feelings of being overlooked or ignored. This coincidentally led to the establishment of Women for Sobriety and Rainbow Recovery. The 12-step concept has been used for other drugs as well. For instance, with Narcotics Anonymous, Al-Anon, which is a support group for spouses, partners, and friends of alcoholics, and Alateen, which is a group for children of parents with substance problems. Finally, here's a list of some of the most common misconceptions regarding substance use. It's a matter of willpower. I can't be an alcoholic if I only drink beer or if I only drink on weekends. I can learn to use drugs socially. And finally, I'm okay now. I could handle using once in a while.